Hello, everyone, and welcome to today's webinar. Minnesota leads the nation in congenital CMV, building the case for universal newborn screening. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Roche Diagnostics. To learn more, visit diagnostics.roche.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Mark Schleiss, Department of Pediatrics, University of Minnesota Medical School, Minneapolis, Minnesota. Dr. Schleiss, you may now begin your presentation.
Thank you very much, and I want to thank LabRoots and Roche Diagnostics. I want to thank all of the members of the audience as well for attending this seminar. We will have plenty of time at the end for questions. Looking through the list, it's quite an eclectic group of clinicians, public health officials, laboratory-based personnel, so it should be an interesting discussion. So I'm going to talk a little bit about our program here at the University of Minnesota and how we've collaborated and interacted with the Centers for Disease Control and the Minnesota Department of Health in moving forward the concept of newborn CMV screening. And we'll touch briefly on the clinical presentation of congenital CMV and discuss why it's important. And we will also talk a little bit about the studies that we've done over the last few years that have looked at the prevalence of congenital CMV in Minnesota. Then we'll move into how this will translate into a new initiative in Minnesota for universal CMV screening through passage of what's known as the Vivian Act. The Vivian Act will enable universal screening in Minnesota sometime in 2023. So congenital CMV infection in symptomatic cases is quite an obvious illness to clinicians, and arguably you wouldn't need a newborn screening program to identify a sick baby with this kind of appearance in the newborn nursery. The petechiae, purpura, large liver and spleen, often occurring in concert with microcephaly, vision loss, and most importantly, hearing loss. And so these cases are certainly quite tragic. Fortunately, this is just a small percentage of all cases of congenital CMV, but these are the ones that capture public attention because of their dramatic clinical presentation. In fact, this is just the tip of the iceberg. Many babies with congenital CMV are completely asymptomatic at birth and actually have a good prognosis for normal outcome, and that complicates the issue of universal congenital CMV screening, as I'll come back to in a moment. We think that somewhere between 15 and 20% of all congenital infections do lead to some sort of permanent injury. And most commonly, that permanent disability is related to sensorineural hearing loss, which may not be present at birth. Babies can, in fact, pass their newborn hearing screen, only to go on to develop hearing loss later in childhood. Risk for the baby appears to be greatest if a maternal infection during pregnancy is the first CMV infection of that woman's lifetime. In other words, a primary maternal infection. And this gives hope to the idea that vaccination could help ameliorate, if not prevent, some, if not most, cases of congenital CMV. And I'll touch briefly on the state of the art of vaccine development. But again, for the purposes of this webinar, we're left with the knowledge that the majority of cases of congenital CMV infection are in fact asymptomatic and have a good prognosis for normal outcome. So what is the basis of screening? Before we get into details about CMV screening, we should draw a distinction between Universal screening, that is to say, all babies born will be tested for CMV at birth, and so-called targeted screening, which is an initiative that has been taken up by many states. In targeted screening, certain risk factors will trigger testing of CMV in the newborn nursery in some infants, most notably babies that refer on the newborn hearing screen, babies that have unexplained premature birth or intrauterine growth retardation, babies who are born to women who have a history of an illness during pregnancy compatible with a CMV infection. Universal screening, again, as the name implies, is testing of all newborn babies. One area of uncertainty moving forward is, what's the proper test? What's the best test? And various publications and studies have compared the value of testing blood in the newborn, most commonly through the newborn dried blood spot, urine testing, which is probably the gold standard for diagnosis, but carries with it a great financial burden because of the cost of the time required to collect those urine samples on all newborns. And saliva. Saliva certainly has some theoretical advantages, including ease of obtaining the sample. But the issue with salivary screening is false positive results in babies, particularly babies who are breastfed, who aren't in CMV infected, but may have CMV DNA in their saliva. Another issue that has complicated newborn screening for congenital CMV is the lack of the endorsement of the newborn screening committee that carries forth the recommended uniform screening panel recommendations, the advisory committees on heritable disorders in newborns and children. The RUSP is a list of disorders that the Secretary of the Department of Health and Human Services recommends for states to screen as a part of their state universal newborn screening programs. Disorders on the RUSP are chosen based on the benefit, the ability of the states to screen, and the availability of effective treatments. Most states will screen for disorders when recommended by this committee. Newer conditions are less clear and may vary considerably from state to state. So at this time, there is no recommendation for inclusion of congenital CMV screening on the recommended uniform screening panel. There are efforts to nominate congenital CMV screening, and these are being evaluated on an ongoing basis. But at this time, it does not appear as though CMV will be added in any short-term window of time, even though it continues to be much discussed by the advisory committees on heritable disorders. So should we include congenital CMV in this panel? Those who advocate for this say yes. If a baby's identified with congenital CMV infection, even if asymptomatic, that's a baby that can undergo a diagnostic evaluation and anticipatory monitoring for sequelae, most importantly, hearing loss. As I've already mentioned, hearing loss may be delayed in nature and it may be progressive in nature. So identifying these babies at birth may be the only way to discover hearing loss in a timely enough fashion to offer intervention, corrective intervention, and therapeutic intervention. Advocates for universal screening also point out that antiviral therapies are available and that these babies can undergo serial neurodevelopmental evaluation that may improve their long-term outcome. On the other hand, those that believe that universal congenital CMV screening is premature and not ready yet for inclusion will point out that most infants are asymptomatic and have a completely normal prognosis. And there's considerable discussion currently about the overuse of antivirals. As I'll come back to in a moment, the only demonstrated efficacy of antiviral therapy in congenital CMV is in babies that have significant symptoms involving the central nervous system at the time of diagnosis in the neonatal period. There's a considerable concern that we're grossly overusing potentially toxic antiviral drugs in asymptomatic babies or minimally symptomatic babies with no direct benefit demonstrable by any controlled clinical trial. I'll come back in a moment and talk in more detail about the concern about undue parental anxiety that might be engendered by a screening test that mostly uncovers asymptomatic children with a good prognosis. And we'll talk a little bit about the cost effectiveness or the perceived or theoretical cost effectiveness of congenital CMV screening. But this is an issue that's also discussed in some detail, not just the cost of the screening test, but the cost of the concomitant evaluations that are undertaken when a positive test is found, including neuroimaging, audiology, and other laboratory costs. It's been questioned whether or not congenital CMV screening fits the RUSP paradigm as defined in the basic tenets of universal screening for congenital disorders. The fact remains, though, that if CMV is to be identified as a congenital infection, timing of specimen acquisition is critical. If a specimen is obtained from a neonate beyond 21 days of age, then by definition, we say that that can't diagnose congenital CMV in a baby that's been breastfed or received colostrum, because CMV seropositive mothers will invariably shed viral DNA and virus in their breast milk. And so shedding of CMV virus by the baby in the urine or saliva beyond 21 days of age may simply reflect postnatal acquisition. As I've already alluded to, there's also uncertainty about the optimal test for screening, whether this should be dried blood spots, very advantageous samples simply because they're obtained on all babies as a part of standard neonatal care. But sensitivity issues have been a major concern. Urine and saliva, as I've alluded to, are alternatives, but since this would require in both instances collection of a whole new sample, whereas the dried blood spots are collected on all newborns in virtually every state in the United States, this adds a lot to the cost of newborn care, and it may be financially untenable. So what about the dried blood spot? The CHIMES studies of the early 2000s, referenced in this slide, raised the issue that the dried blood spot PCR may be insufficiently sensitive. In the initial report of over 20,000 babies, the range in sensitivity of the dried blood spot was only in the order of 28 to 34%, whereas saliva PCR demonstrated a high sensitivity of greater than 97%. These are the references that go along with these papers. And so we set out a few years ago to reevaluate this issue in light of improved DNA recovery methodologies that have been described since the original CHIMES study. These consist of both improved extraction buffers as well as increased sensitivity of DNA extraction platforms. The hypothesis going into our study was that the improved methodologies may translate to a better sensitivity of the dried blood spot PCR than those studies that were reported 15 years ago, and that this might support reconsideration of the dried blood spot as a tool for universal screening. So we set out to compare the analytic sensitivity of saliva and dried blood spot for CMV detection in a prospective, unselected, population-based study in Minnesota. So here's Minnesota in red, as you can see, for those unfamiliar with the geography of the Midwestern United States. We border Ontario, which interestingly is the first province in Canada to undertake universal congenital CMV screening. And we looked at these Twin Cities nurseries, shown in the red black arrows, as well as an upstate nursery in St. Cloud, Minnesota, and obtained samples prior to hospital discharge in the newborn nursery following informed consent that consisted of a saliva swab, as well as a consent to punch three 3-millimeter punches for each of our labs. The Minnesota Department of Health sent 3 of these punches to the University of Minnesota and 3 to the Centers for Disease Control. So 6 punches in total. The dried saliva swabs came to my lab at the U of M. Our lab uses a QIAcube extraction technique and a PCR assay based on the UL83 gene of human cytomegalovirus, whereas the CDC lab performed manual extractions with a PCR for IE1. And we simply asked, what was the comparative sensitivity of our 2 labs? How did this compare to saliva PCR? And then what did we do with a positive result? Positive result triggered a report from the Minnesota Department of Health Newborn Screening Program to the primary care physician. And so that was another aspect of this study that I think was very important. The question of whether universal CMV screening could be inculcated into the workflow of the state newborn screening program, just as they would a positive screen for hypothyroidism or galactosemia. These 2 are reported to primary care practitioners who then arrange for confirmatory testing and secondary evaluation. The secondary evaluation was performed using the criteria put together by this international consensus panel and published in The Lancet a few years ago now. First and foremost, a confirmatory urine PCR, again, aiming to collect it before 21 days of age. Then a laboratory evaluation looking at the CBC with special attention to the platelet count, an important biomarker predicting risk in congenital CMV, liver function tests to look at transaminitis, serologies, blood viral load by conventional PCR, not research-based PCR with the dried blood spot in this case, but actual PCR of infant blood. And then audiology and ophthalmology referrals. Neuroimaging was conducted by head ultrasonography, and these babies are currently being followed up for long-term neurodevelopmental as well as audiologic issues. The Lancet criteria breaks congenital CMV infection and disease into 4 categories: moderate to severe symptomatic illness, mild illness, asymptomatic illness with isolated hearing loss, and asymptomatic illness. And the only category for which antiviral therapy has been shown in any kind of controlled setting to be useful is moderate to severe illness. These were our data as of earlier this year, out of over 20,000 screens, an overall prevalence of congenital CMV of about 1 in 200 babies. You can see the maternal age breakdown. And in Minnesota, we've often been characterized as a population that's predominantly Caucasian, but interestingly, we found in this study that the race demographics of our screening study were essentially identical to those of the United States as a whole, with about 12.3% African American or Black participants in the study. We then decided that we would move forward with diagnostic comparisons of saliva and dried blood spot. And this is what the data show, that when we compare the sensitivity of the dried blood spots done both in the Minnesota lab and the CDC lab, we had an analytic sensitivity of about 86%. This is strikingly better than originally described in the CHIMES studies of the early 2000s. When we look in greater detail at the clinical sensitivity, this number goes up into the 95% range. In other words, clinically important congenital CMV that falls into those 2 symptomatic risk categories or the category of asymptomatic except for hearing loss, yields an even better sensitivity. So this was reassuring information that I think is reflected in the field in another look at dried blood spots as a tenable alternative for diagnosis of congenital CMV. When we looked at the demographics of our CMV positive infants, we found that birth order had quite an influence, a p-value of 0.02 favoring second pregnancies or higher. And most of these babies with congenital CMV in our cohort over the last 5 years have been born to families where there is an older toddler attending group daycare. We've looked more recently at the impact of the COVID pandemic on the prevalence of congenital CMV. Prior to the COVID shutdowns that we all experienced in early 2020, we'd screened just under 20,000 babies with a prevalence of 0.45% pre-pandemic. Since the pandemic lockdowns, we've seen a striking decrease in the total number of babies positive for congenital CMV, with a post-pandemic prevalence of 0.15%. This in spite of the fact that the collection of samples, the research methodologies, the PCR testing, the technical aspects of the assays were completely unchanged. So I think this teaches us something about preventative strategies for congenital CMV, namely the idea that isolating, hand washing, hygienic precautions. The other notable aspect of the pandemic lockdown was far fewer children attending group daycare. Now, data I don't have to show you today, but that has become evident just in the last few weeks, has shown that since we've opened up again, we are now seeing a return to the pre-pandemic prevalence. And so I think the pandemic has taught us something interesting about CMV prevalence. Overall, pre-pandemic, through the pandemic, post-pandemic, still between 0.4 and 0.45% prevalence, pretty similar to what's been described in other studies in the United States. But again, a major impact of the pandemic. What about the babies? We have found that most babies, as predicted, are asymptomatic. 17% fall into a symptomatic category. Most of these are mildly symptomatic infants. And 16 babies have been treated with Valganciclavir in this study cohort. This is the publication from JAMA Pediatrics last year, showing the enhanced sensitivity of dried blood spot testing for detection of congenital CMV infection. And I just wanted to share with you on the saliva swab here on the left, you can see in dark blue all of the true positives, that is to say those tests that ended up being reflected in a baby with bona fide congenital CMV. But in yellow, the false positives. We did have some false positive PCRs in babies that ruled out for congenital CMV. And when I say false positive, I believe that there was CMV DNA present. We were able to trace a handful of these positive results to a specific nursery in our study nursery cohort where donor milk is commonly utilized, suggesting that that may have been a source for CMV DNA. In contrast, though, we only saw one false positive dried blood spot in a baby that ruled out for congenital CMV. So I think as the field moves forward, this is going to continue to be an open point for discussion, the role of saliva testing. There are a number of clinically marketed saliva-based testing methodologies that are currently either available or in development or deployment. And how these will be incorporated into targeted or universal CMV screening programs remains to be determined. So does CMV fit the paradigm of newborn screening? The newborn screening story begins with one simple test, and that's the test for phenylketonuria. And here's the slide demonstrating the autosomal recessive segregation of the PKU gene that leads to abnormalities in the metabolism of phenylalanine. PKU testing, which was developed by Dr. Bob Guthrie, who's been named the father of newborn screening in some publications, is an area of interest, a personal interest for me, simply because Bob Guthrie attended the University of Minnesota, where I'm on the faculty. And he, of course, was driven by a number of family members with PKU. It's interesting looking back at the papers of the day when this test was moving forward to the clinic, and the strong pushback that existed from organized medical groups, including the AMA, as well as other editorials from thought leaders who were very opposed to incorporation of newborn screening for PKU into clinical practice. The argument was that PKU screening, again, some of the same arguments we hear with CMV, may generate false anxiety and lead to unnecessary concern. Moreover, there were comments in some of the editorials of the time that the test had not been shown to be cost effective and had not been properly validated. Again, some of the criticisms we hear about CMV testing. PKU testing, of course, is done on the dried blood spot. And the principles and practice for screening of disease articulated by Wilson and Junger in 1968 are still used today when discussing whether we should add CMV testing to the universal newborn screening portfolio. Is it an important condition? Is there a treatment available? Are there facilities for diagnosis and treatment? Is it a diagnosis that's difficult to recognize early? Certainly is true of CMV. Is the screening test suitable? Again, that's argued with CMV, especially with the dried blood spot, which, although I think has an enhanced sensitivity compared to the CHIME studies of the early 2000s, still is not a perfect test. And what do we know about the natural history? The vulnerable child syndrome has been articulated as a concern for universal congenital CMV screening. And this paper by Gievers et al. Actually called into question the ethics of targeted and universal congenital CMV screening because of concern that it might create undue anxiety for parents. I think these kinds of arguments and positions are extremely important and need to be discussed. But we also need to balance this with concerns about excessive paternalism in clinical practice. The idea that we may have a test available, but that parents should not be empowered with having the information because, as doctors, we know best. We know this is really nothing to worry about. We don't want to create undue anxiety. In fact, if we go through the Wilson and Junger checklist, I think CMV checks all the boxes. It's something that we can treat, and bear in mind that treatment of disorders in clinical practice is so much more than just writing a prescription for a medication. Treatment is audiology, it's anticipatory guidance, it's monitoring these babies' development. We do have facilities for follow-up. Long-term disabilities are incompletely defined, but there is a recognizable latent phase in these babies who may not declare with their hearing loss or developmental delay until later in childhood. We are, I think, now at the point of having a suitable test for examination using dried blood spots. The test should be acceptable to the population, and parent groups again and again have endorsed and supported the idea of CMV testing, even if they know that the outcome may be uncertain in some cases. Outcomes vary with congenital CMV, but we all agree that monitoring is essential. A policy for congenital CMV testing, screening, and treatment is something that continues to be much discussed, and I hope to see the RUSP take this on in future iterations. But cost effectiveness of CMV screening has been supported by modeling studies. Universal CMV screening has been in place in Ontario, Canada for a couple of years. And the test, I think, is sufficiently sensitive to warrant adoption into clinical practice. This is an important paper in JAMA Pediatrics by Soren Gant and colleagues, and I'll call to your attention, that does analyze the benefits of CMV screening based on not only the anticipated benefit of antiviral therapy in affected babies to reduce hearing loss and improve developmental outcome, but also the benefits of earlier identification of hearing loss. And congenital CMV screening is very much tied in with the EDI mandate of early detection and intervention to improve hearing, speech, and language outcomes. And it's not surprising that in Ontario, it was really the EDI program that adopted CMV screening before the newborn screening panel in the health department. This is also data, and there are several studies similar to this one, that in surveying caregivers, families, the vast majority would want to know if their baby had congenital CMV, even if it never caused any problem for that baby in the future. And so I think these kinds of focus group analyses are extremely important. The initial positive newborn blood spot results could cause some stress and anxiety, but most parents still overwhelmingly support routine newborn screening for congenital CMV. The other point I would make is that the Wilson and Junger criteria are being rethought in the post-genomic age. When Wilson and Junger published their algorithm for newborn screening for heritable disorders over 50 years ago now, they never could have anticipated the availability of a whole exome sequence on a young baby in a matter of days or even hours at a reasonable cost. The idea that in the genomic age, these criteria might not hold up, I think, is important. Many of them are fundamental and important, but we need to expand on them, and we need to recognize that in an era of sequence analysis and advanced genetic analysis of pediatric health, that the Wilson and Junger criteria may need to be revisited. And then lastly, I would make the point that health equity and access is really a critical issue, and one that I think needs to be more regularly discussed. It's one thing to market congenital CMV testing kits that might be done electively for those who have resources and the availability to pay. But I believe that health equity and uniform access is critical. We need to make sure that all babies are tested if we're going to undertake testing, recognizing that congenital CMV is very much a disease of health disparities that disproportionately targets Black and African American babies. So we need to keep this in mind, and that's why I believe state health departments should be taking the lead to ensure equity. Well, ultimately, the prevention of congenital CMV could depend upon licensure of a successful vaccine. And I just wanted to spend a couple of minutes to update this audience on some developments in this space. CMV vaccine research began all the way back in the 1970s. And there have been a number of studies that have shown varying degrees of immunogenicity, and in one study, a modest success against acquisition of infection, but not successful enough to merit licensure. And so none have been successful if success is defined as bringing a product into the clinic for licensed use. This is surprising in light of the fact that the Academy of Medicine in the early part of this millennium identified a CMV vaccine as the highest level 1 priority for new vaccine development in the United States. We have seen progress in recent years. We've seen evaluation of mRNA-based platforms in phase 1 and phase 2 studies, and now in a phase 3 study. We've seen protein subunit vaccines in preclinical and phase 1 study, but there's no licensed CMV vaccine available yet. Just to review this complex virus, this cartoon shows the CMV particle. It's the largest human virus, both in terms of size of the virion, the virus particle, as well as in the number of encoded gene products. Over 200 open reading frames defined in the late 1990s by DNA sequence analysis, and now with splice variants and alternative codon usage patterns, it appears that there may be as many as 800 unique open reading frames encoded by CMV. Of all of these open reading frames, the ones shown in the cartoons as the envelope glycoproteins, including the glycoprotein B and the so-called pentameric complex, are the leading candidates for phase 3 study currently. There are also proteins in the layer between the viral envelope and the nucleocapsid known as the tegument, in particular one known as PP65, that is in several CMV vaccine candidates, and a non-structural protein, the so-called IE1 gene. These are the various platforms that have gone into the clinic or are approaching human clinical trials. These include virus-like particles, vectored vaccines in which the CMV genes are expressed in another heterologous viral vector, somewhat similar to one of the COVID vaccines licensed in the United States. There are nucleic acid-based technologies, and again, by analogy with COVID-19, mRNA-based vaccines with CMV gene products. Live attenuated vaccines or disabled vaccines, DISC, an acronym for disabled infectious single cycle, meaning the virus can get in, express its gene products, but it has a genetically programmed dead end. It can't replicate and make replication competent virus. And then what we would now call, I guess, old-fashioned vaccines based on protein subunits mixed with adjuvants. And one of these vaccines, the GB subunit admixed with MF59 adjuvant, an adjuvant that's now approved for human use in a flu vaccine, did show about a 50% efficacy in young women against acquisition of a primary CMV infection. Finally, peptide-based vaccines, which may be more useful ultimately for control of CMV disease in transplant patients rather than pregnant women. These are a couple of current studies. One, a attenuated DISC virus, the V160 vaccine, and then an mRNA-based vaccine, which encodes CMV gene products that are inclusive of the GB and pentamer or pentameric complex that I mentioned a moment ago. Well, just to finish up, we'll talk now about what's going on in Minnesota. And this effort started a few years ago, about the same time we were starting our collaborative dried blood spot screening study in collaboration with the Minnesota Department of Health and the Centers for Disease Control. This was a completely separate initiative undertaken actually by parent groups, including the mother of one of my patients, a woman named Leah Henriksen. Her daughter, Vivian, had symptomatic congenital CMV infection. And so we talked in 2016 about how it would really be useful to approach our legislative representatives in St. Paul to explore the possibility of a CMV bill, initially hoping that we would, in Minnesota, like many states, be able to procure funding from the legislature to hire an individual who could improve knowledge, education, and awareness of CMV. Knowledge, education, and awareness of CMV have been a big problem. You can see on the left the total number of infectious causes of neurologic damage in infancy, and CMV is more significant than congenital rubella or Haemophilus influenzae meningitis, diseases that have now been largely solved by vaccination. And yet, when we look at knowledge and awareness of the condition among women, CMV, even though it's more common than all of these other infections and diseases, fetal alcohol syndrome, spina bifida, SIDS, Down syndrome, HIV, almost all women know about these diagnoses, but if you add them all up, it's fewer cases of damaged babies every year than CMV, which is the least well recognized. So we were hopeful that we could pass legislation that would increase knowledge and awareness of CMV. Well, the years went by and we had some progress with the bill. We were able to get it to the governor's desk in 2018, but it was unfortunately vetoed as part of a larger omnibus veto. And yet the parent groups kept increasing. Other parent advocates, including Steph Steidel and her son Hank, identified by our universal screening study, stepped up and redoubled their efforts to try to get the legislators to recognize and talk about this. After several years and several efforts, we really began to make headway in 2021 at committee meetings, hearings, discussions, and we managed to make it all the way to passage. And so the Vivian Act was included in the Senate Health and Human Services budget. At this point, we decided to go for broke and not just include knowledge and awareness, but also universal screening. And Senator Karen Housley was the leader, but had many, many co-sponsors on the bill, both in the Senate as well as in the House of Representatives, that got this bill to the finish line. One of the hallmarks of the bill was that once passed, it had to be approved by the Minnesota Commissioner of Health, who sent it back to the newborn screening panel for a series of meetings and discussions in the fall, some evidence-based analyses. And after these hearings and sessions, a vote was taken, not a binding vote, but a vote to support the measure, and it did pass overwhelmingly, and went back to the Minnesota Health Commissioner's desk in February, who then signed off on the legislation. So over the last few months, the Minnesota Department of Health has been working on trying to develop a plan. And the rollout hopefully will be to begin a universal screening program in 2023. As a part of the legislation, funds were allocated to pay for the testing, as well as a position for an educator who would be charged with increasing knowledge and awareness, not only among young women of childbearing age, but also healthcare practitioners, daycare providers, and indeed all occupations where there's extensive contact with young children. Currently, there are discussions about how to screen. Will it be the dried blood spot? Will it be some other methodology or approach? What will the laboratory protocols consist of? What primers by PCR will be utilized? What cutoffs and controls? How will the information flow through the notification system? This is something, fortunately, we've had some practice on in our studies to date, namely the study that inculcated congenital CMV screening into the newborn screening program, just like any other screenable disorder. How will the notification system then flow, and what will the follow-up be? Will the follow-up consist of the Rawlinson et al. Criteria analyses, as I've outlined, that include head ultrasonography, laboratory assessments, confirmatory virology? That's critical, especially in the first 21 days, as I've alluded to. To what extent will this be undertaken by primary care practitioners? I think one of the bigger challenges may not be the expertise of primary care practitioners throughout Minnesota, but simply the availability of those trained adequately in pediatric audiology and to some extent radiology. The reading of a newborn head ultrasound may not be a test or an evaluation that most general radiologists are immediately comfortable with. So a number of working groups are in the process of being formed, and there will be an active discussion about these issues. And then interfacing results with other parts of the Minnesota Department of Health, including early hearing detection and intervention, or EHDI, neurodevelopmental assessments through the educational department, and the Child and Family Health Division in the Children and Youth with Special Health Needs section of the MDH will also be involved in these discussions. So it's going to be complicated and extensive and a work in progress. But we are excited about it, and we're excited about being the first state in the United States to endorse and codify universal screening. And I hope to be able to come back in the future and update you about how we are progressing. Some questions that will come up, not only for Minnesota, but all states. Will this be endorsed as an addition to the RUSP panel? What do we do with the fact that this still doesn't quite fit the paradigm of most screenable disorders, most of which have a really worrisome outcome if they're not detected? Well, that may not be true for congenital CMV. The ongoing assessment of test sensitivity is going to continue to be important. I think we're poised at an 85 to 90% sensitivity of dried blood spots to not let the perfect be the enemy of the good. We can do a lot of good and help a lot of babies by commencing dried blood spot screening with our current methodologies. But these need to be constantly looked at, and new and better approaches will come forth in the future. And that's been true for all screenable disorders in newborn screening. Continuing to look at the costs is going to be critical. And then reflecting how this will become a part of what is arguably a changing landscape in newborn screening in the advent of the molecular era. What other changes might we anticipate for other potentially screenable disorders? That will be an interesting discussion to participate in the future as we move forward. So with that, I want to stop and look forward to hearing your questions. This slide is sadly not comprehensive, but it does capture at least a lot of the people who've played critical roles in these collaborations, including Sheila Dollard at the CDC, Tatiana Lanzieri, also at the CDC, Mark McCann, the director of the newborn screening program at the State Health Department in Minnesota, and Sandra Rosendahl, who's been the genetic counselor and director of notification for newborn screening results, Kirsten Coverstone in our EHDI department, other laboratory staff and personnel, our state epidemiologist, a pediatrician, Ruth Linfield, who's been very supportive of these studies. This has been a study not only done in our University of Minnesota healthcare system, but Allina Health, which is another health system in Minnesota, Abby Sidebottom, who's the director of research there. Then people in my own group and laboratory, shown here in front of the laboratory at the University of Minnesota, and listed over here on the right side of the slide. Incomplete, but at least a reasonable list of all of the collaborators and ancillary staff who have helped make this work possible. So I think with that, we will move on into questions, and I look forward to hearing your questions and comments.
Thank you, Dr. Schleiss, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. All right, let's get started. Our first question here asks, there are some commercial platforms available that do rapid bedside testing of saliva to look for CMV DNA. Could these be used for universal congenital CMV screening?
Yeah, I mean, it's such an important question as we see these platforms now. Some of them are licensed and marketed. How should they be used? And I think that there is a role for these. Targeted screening of babies that refer on the newborn hearing screen would be one such role. Whether these would be adaptable to universal screening, I think we'll see. I mean, this is one of the deliberations that the Minnesota Department of Health Newborn Screening Program will be discussing as they develop an implementation plan. I've been an advocate for the dried blood spot because I believe it has a clinically tenable sensitivity and a better specificity, that is to say, fewer false positives as one might see with saliva. My other concern about some of the platforms that are being marketed for saliva testing could be their cost, and this could circle back to health equity issues. In the state health department, there's a premium on finding a sensitive test at a minimum cost so that it's available to everybody. And I think that the cost of the bedside fee-for-service marketed platforms is something we need to consider moving forward. But it's a great question, and I like the idea of dried blood spots for the other reason being that they're collected anyway. I mean, we get them on all newborns, and so it's much less of a cost to the system, because let's face it, in the United States of America, the most costly thing in healthcare is the cost of people's time. And so the additional time required for nursing staff to obtain additional specimens, whether it's saliva or urine, is a concern that needs to be considered.
Thank you. Next question here. Should a baby that screens positive for CMV be treated with antiviral drugs like Valganciclavir?
Yes, well, thank you for that question. I think that circles back to some of the comments I was trying to make about the concern about the overuse of ganciclovir or valganciclovir. Let's not forget that this is a drug that has significant toxicities. Upwards of a third of babies may develop clinically meaningful neutropenia on long-term valganciclovir therapy. There's a cost associated with the frequent laboratory monitoring that's required for safety. And we need to be mindful of that. Now, there are other drugs in the pipeline. Letermovir, for example, has been licensed for prophylaxis against CMV disease in transplant patients. I think that we don't know anything about it really in infants, but maybe in the future we will see better tests available for antiviral drugs, looking at the sensitivity of the virus and the need for the reduced need for safety monitoring. But right now, I think that asymptomatic babies with congenital CMV should not be treated with antivirals.
Great, thank you. Next question here. If a screen comes back positive from the state laboratory for CMV, can you assume that the baby has congenital CMV infection, or is additional testing needed? If you need additional tests, how soon do they have to be performed?
Yes, and so as I alluded to, I mean, yes, you definitely need a confirmatory test. And so in this way, it's no different than hypothyroidism or another screenable disorder in the newborn panel. And my recommendation is a urine test that should be obtained prior to 21 days of age. We cannot conclusively make the diagnosis of congenital CMV on a positive screen alone. That's why it's a screening test.
Thank you. Next question here. What were the key elements to be able to get universal screening for congenital CMV tests approved in Minnesota, even though it's not on RUSP list?
Yeah, I guess in a word, moms, lobbying in force and fashion. Even though I am not much of an expert at all on social media, moms are, and they use Facebook and other platforms to very nicely mobilize people. We had a rally actually out in front of my lab last spring. We had legislators attend. It was really just a grassroots lobbying. And one of the things that made it really fun is that this all happened without endorsements of formal thought leader bodies. We didn't have commercial sponsors. It was all grassroots lobbying by parents and families. It was really democracy in action. And for those of us who still believe in democracy in the United States, it was very refreshing.
Great, thank you. We have time for a few more questions here. So this next one asks, when talking about CMV and organ transplantation, I had heard that there is a great percentage of people that were unknowingly positive for the CMV antibody. Does this say most people have been exposed to the virus and that they carry an inactive form of it?
Yeah, so a good question. I would say it means most people are infected, not just exposed, they're infected. And I think probably 5/7 of the world's population today has CMV infection. Most people in all of human history who have had CMV probably got it from breastfeeding, mother's milk. And most people are asymptomatic. In the hundreds and hundreds of moms I've interviewed over the years, very, very few of women have ever relayed a specific ailment during their pregnancy that made me think of CMV or made me think they had a symptomatic CMV infection. Most CMV infections in pregnancy are asymptomatic. The other important point in that question, and I thank the person who asked it for bringing this up, is CMV infections, congenital CMV infections, actually occur in women who have longstanding immunity. And so that's the great enigma of CMV, is having had infection does not protect you for life against reinfection. It's quite fascinating, the parallels with COVID-19, where we're having these same discussions. Strain variants, new strains emerging. Women can get reinfected during pregnancy, even if they're seropositive. So that's why universal screening really is a paradigm that should be exercised for all women, irrespective of the serologic status. It's a debate worthy of a whole other webinar, whether or not all pregnant women should be screened for CMV antibodies. But what I've argued is that whether you're CMV seronegative or seropositive, you are at risk for either acquiring CMV primary infection or reinfection during pregnancy and transmitting that to your baby. And so that's why universal screening of the newborn, I think, is really important. Now, you're less likely to have a symptomatic or damaged baby if it's a reinfection, but still 15 or 20% of those babies go on to have hearing loss. And so you can't rely on the presence or absence of symptoms at birth. That's why universal screening is important.
Thank you. Next question here. What are the positive and negative predictive accuracies of DBS screening for cCMV?
Yeah, great question. The positive predictive value and for that matter, the negative predictive value are both in the 90% range. And so we didn't see any surprises there. We know that the positive predictive value of any test depends on the prevalence in that population being studied. The reason it was not 99.9% is we do have some false positives with saliva. But the dried blood spot, on the other hand, very few false positives. So I think the predictive values, at least in our study, were quite robust.
Well, it looks like we have time for one more question here, so we'll wrap up with this one. And it asks, what specimen type and testing platform are being used in Ontario for universal screening?
Yeah, so the Ontario platform is a real-time PCR platform being done on dried blood spots. And the primers and amplification conditions have not actually been published yet. For those that are interested, there will be a workshop in Canada, Congenital Cmv meeting, the last week of August. And so for those that would be interested in a deeper dive, it's a great meeting. It should be a very good meeting for Congenital Cmv with a lot of information on screening. And I think we'll hear from the Ontario group. There's currently work in progress to add screening in Saskatchewan and a couple of other provinces. But basically, the platform is a real-time PCR, and it's also being done in conjunction with screening for connexin mutations, GJB2, the gene product that's the most common genetic cause of deafness in North America. And so we look forward to seeing the Ontario data published and comparing notes with them. I think that'll be extremely valuable.
Great. Well, thank you again, Dr. Schleiss, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Roche Diagnostics, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.